started. Good morning, everybody. I am Alan Short. I'm the chair of the Department of Pediatrics Grand Round Committee. So today I will be introducing Dr. Natalie Pageler, and then Dr. Pageler will introduce the rest of her team. I've known Natalie since residency and possibly even since med school. She's a Stanford lifer. She did med school, residency, fellowship, and now has been on here on faculty for a number of years, and I hope it will stay that way indefinitely. She clinically is one of the best intensivists and teachers that I know, but of course, the hat that we will be hearing about today is her informatics hat. She has been our CMIO since 2016, had many accomplishments in that role, including starting the first, I believe, the first clinical informatics fellowship in the country, which she currently directs. She's won numerous accolades and awards. My favorite is that last year she was named by YWCA Silicon Valley as one of our most influential women, and I absolutely agree with that. As we will hear today, she's been a trailblazer. She and her entire group have been trailblazers for telemedicine, which I believe is here to stay. So Natalie, take it away.
Wonderful. Thank you, Alan. You are way too kind, but I really appreciate the introduction. And it is my great pleasure to introduce my colleagues. First of all, Vandna Mittal, who is our Director of Digital Health. Unfortunately, it is my sad duty to inform you all that this is her swan song with our organization because this is her last day with us. She is moving on to a very exciting new role with a startup company called Freenome that does early cancer screening and personalized treatment for cancer, which she is very excited about. And I will just start with the claim that it was not COVID that chased her away. She had actually made this decision prior to COVID and was gracious enough to stay with us for the last month and a half while we got through this particular crisis. So very, very grateful for all that she's done for this program for the last 3.5 years and excited that she's gonna be able to share her work with you today. And then additionally, we have Tzielan Lee, who is my partner in crime. She is the Associate Chief Medical Information Officer over Ambulatory, as well as the Associate Medical Director of Ambulatory, as well as Associate Fellowship Director of the Rheumatology Fellowship. So has very, very many hats, and you all know her well from all of her great work with telehealth. So we will be talking about telehealth, pediatric and obstetric telehealth, with particular consideration of the impact of COVID-19 on the dramatic explosion of telehealth over the last month and a half. Unfortunately, we have no conflicts of interest to disclose, but we will be talking about kind of a wide range of topics. So it's going to be a whirlwind tour. We'll be giving a brief history of telehealth, talking about telehealth in the ambulatory setting, inpatient setting, and its impact on clinical research, and then give you a little glimpse of what's next. So with that, I'll hand it over to Vandna.
Thank you, Natalie. Thank you so much. So next slide, please. So just before we begin the talk, I want to make sure that we're all using the same definition throughout the course of this presentation. So we took the definition from the state of California to say telehealth really is a tool used in medical practice, and it's not separate from a separate form of medicine. And actually, telehealth is not brand new to the field of medicine. And I put on this picture from 1924 radio news where somebody was very visionary predicting what telehealth could look like by leveraging radio technology. But it wasn't really until 1948 when we had radiologic images being transferred by telephone in the state of Pennsylvania of a distance of 24 miles. And then from there in 1959, we had the first traces of the medical use of telehealth through video communication. Next slide, please. So just to set the stage a little bit more, prior to COVID-19, telehealth has always been something on people's mind, but you can see from this research study the search of telehealth and telemedicine was pretty minimal. Once we began to see the increase and rise of COVID-19 cases, we saw the increase of search volume across both telehealth and telemedicine. This data was taken through Google Trends and through Google search. Next slide, please. Telehealth is not brand new to Stanford Children's. In 2013, Dr. Bill Kennedy from Urology received the first grant to set up clinic-to-clinic telehealth. He actually used a closet at one of our multi-specialty sites to redesign it as a telehealth dedicated room. Next slide, please. This is a slide to share with you the number of unique providers and the number of unique patients that have been touching our telehealth platform. So you can see prior to COVID-19 in our fiscal year, which starts on September 2019, we had around 100 providers using our telehealth platform. And as COVID-19 began to ramp up, it really had a steep increase between 561 to 716 unique providers touching our telehealth platform. And then the same for patients. We had about 250 to 300 patients using our telehealth platform, but then it's steeply increased to over 11,000 in the month of April. And then prior to COVID-19, this is a core goal of ours across our organization. We like to measure patient experience and specifically the likelihood to recommend as one of our core goals. And so starting in September of 2019, we were at 78.3%. And you can see as COVID-19 began to ramp up, our patient experience, a likelihood to recommend increased to 85%. And we'd like to think that's partially attributed to the increase of telehealth. Since during COVID-19, we've been seeing over 54% of our total visits via telehealth. So one thing that we'd like to really emphasize is our patient portal. Our patient portal is really the gateway for our telehealth tools. Prior to COVID-19, we were one of the highest organizations with the highest activation rates for pediatric hospitals. And this is something really unique. If you think about a patient portal, you're really giving access to patient medical files, but it's a little bit more complicated with pediatrics because in a pediatric setting, it's the child, but then you're giving access to that caregiver, whether it's a parent, a guardian, or somebody else. And so you have to first establish that relationship that this person is actually responsible for this child before they can get access to that patient portal. So there's several steps to ensure that this patient portal is provided access to. And the activation is a little bit more complicated versus an adult activation strategy. But Stanford Children's has been wonderful with this. We obviously have had a high activation rate. In September of 2019, we saw about a 68% activation rate, and that has continued to increase over the duration. And as COVID-19 began to ramp up, we also saw our patient portal activity and the activation increase all the way up to 87% in our network community, as well as 82% in our faculty practices. Now, one of the reasons we do find this to be really important strategically for our digital health goals is because the patient portal is how patients get access to our telehealth services. It's the way they can message our providers very securely and share images, as well as get access to their medical records. So this is an example. This is an image and a screen of what eCheck-In looks like within our patient portal. It confirms the patient's personal information. It allows families to pay their co-pays, confirm their insurance, and then we also just went live with e-signature to be able to sign the documents of outpatient terms and conditions, as well as notice of patient privacy. And this is really key because as we're able to enable this, we're now able to expand to a completely virtual experience for both new and existing patients. And this is quick data to share with you, as we began to launch eCheck-In, e-signature, prior to COVID-19, we only saw about 1,300 patients complete the eCheck-In process. But as COVID-19 began to ramp up, we saw over 5,900 families complete the eCheck-In process, and of that, 84% were telehealth visits. So what's beyond telehealth? Telehealth is definitely one aspect of virtual care, but we're also enabling, and we have enabled e-consults, which is an asynchronous format of care, allowing a MD in a community setting to gather an e-consult with somebody in the specialty side. We're also looking at e-visits where patients can upload images or fill out a questionnaire, and then providers at their own time can respond back. We have enabled virtual second opinions where anybody across the world can request a second opinion from our specialists, as well as remote patient monitoring. And we're continuing to look at all of these to understand what is the holistic end-to-end workflow for virtual care. One of the most important things that, as a result of telehealth and in-person care, we always are looking at socioeconomic barriers and issues that may arise with different models or modalities of care. While telehealth does highlight some socioeconomic barriers, it also does cover and help solve some other socioeconomic barriers. So we're all familiar with the digital divide related to the lack of access to devices, broadband internet access, cultural, economical, educational barriers, privacy concerns, especially when you're looking at teenagers, who want to do a private consult in child psych, and policy and reimbursement concerns as well. And this is from Pew Research, and this shows you how of the smartphone usage, it continues to increase, and 81% now of our population has access to smartphones, giving us hope that, as more and more folks and patients get more access to these type of devices, we can continue to build off of these smartphones to provide more healthcare services. Something Stanford Children's is really focused on is telehealth access and equity. So some of the things we helped put together, Lisa Chamberlain and Karen Ayer from CI Informatics team, as well as the social work team, helped develop bilingual resources and guides by county for the patients. We've also helped socialize internet access through free temporary internet services that are being offered, especially during the COVID-19 environment. And we're also really thoughtful and trying to figure out, how do we make it more accessible for patients who don't have devices to be able to do a telehealth visits? How can we get it in their hands? And two examples that we've seen happen is many of our schools, local Bay Area schools and across California, have provided patients with Chromebooks or other devices. And then Dr. Priya Prahlad from endocrinology has been providing devices to her patients in a type 1 diabetes studies to help make sure that we can have a more inclusive approach to research in virtual care. And then one of the biggest highlights and things that we're really thinking about is telehealth language barriers at Stanford Children's. And we've been able to resolve a lot of this and solve a lot of this through integrating an interpreter's workflow, providing our patient portal in Spanish, and creating a telehealth patient support model that offers Spanish speakers. And then our telehealth website is also offered in Spanish as well. So I'm going to hand it over to Tzielan now, who's going to be talking about telehealth in the ambulatory setting.
Thanks for having us. I want to just talk a little bit about ambulatory telehealth. Our road to telehealth has really been slow and steady in the ambulatory side, starting over 2 years ago, as Vandna was talking about, averaging about 25 visits per day. Research suggests that in order to get patient and family engagement, they really have to become familiar with the platform and to trust it. And that's what we were working towards slowly. What we've found, though, when you have a pandemic condition, that it increases the preference very quickly. Patients become very familiar with telehealth, and it becomes their preference. So it's really one silver lining to the COVID pandemic is that we really got engagement quickly. And I had a provider prior to COVID tell me that telehealth was absolutely not able to be work in their specialty, and currently that specialty is 100% telehealth. So I really feel that this will change our approach to healthcare delivery moving forward in the ambulatory space. With regards to impacts of telehealth in ambulatory, I wanted to highlight both provider and patient perspective impacts. First, with provider, it broadens perspective. Developmental behavior specialists can observe their patient on a playground, interacting with their family members. An occupational therapist can actually watch a patient eat at the dinner table. Orthopedic surgeon can watch a patient going up the stairs. So it really does broaden perspective. The past month, I've had a lot of video visits where I've been able to meet many family members, including furry four-legged ones, and really just establishes connection with the patient and gives you a broader picture. In addition, it improves coordination of care by increasing communication and decreasing episodic care. It can link primary and specialty care. The functionality of the multi-party platform really enhances the visit. You can have both parents calling in from different locations. You can have an interpreter, or nurse specialist, social worker, and even other specialists join in. A study that was a randomized controlled study really looked at traditional healthcare coordination versus coordination plus a telephone versus coordination plus telephone plus video. By the end of the study, the video group really showed a lowest mean and total number of unplanned visits. With regards to access, a recent AAP policy statement highlighted the use of telehealth to extend pediatric subspecialty to areas that have workforce shortages. And these models really support telehealth. This map that I'm showing is actually a map of our pediatric rheumatologists in the United States. And the green states show states that have less than 3 pediatric rheumatologists. The blue states show states that have 1 or less. So there is a lot of need, and we need to get physicians where they need to be, and telehealth will help support that. Lastly, with increased provider wellness, definitely telehealth makes work more flexible, working closer to home or actually at home. In addition, within the COVID-19 conditions, we're obviously providing a very safe way to deliver healthcare. Next slide. With regards to patient and families, medical care really disrupts families' lives. So the more we can decrease the disruptions, the better. By using telehealth, there's less missed work and school, which translates to cost savings for the family as well. This study from an urban pediatric telehealth program was shown to reduce the number of child absences caused by illness by more than 63%. Patients and families are able to continue the rest of their non-medical day. Dad is able to make dinner, mom is able to make it to the meeting. I've seen patients where they are at, whether it be at their fraternity house, at college, at their school at lunchtime. One patient actually wanted to show me the lake by their house, and we did a video visit together around the lake, which was their positive space. With regards to an autonomy, we really know that it's important to enhance autonomy in the adolescent group. With telehealth, I've seen adolescents take over the visit, become more, because they're really comfortable in front of the screen, and I'm able to have a very a nice conversation with them. For some reason, a screen makes it easier to talk to a 3-year-old as well as 17-year-old boys. Lastly, there are confidentiality issues in adolescence, and telehealth has actually been able to be used for this. Services such as reproductive health, mental health, substance abuse treatments, and even treatments for sexually transmitted diseases. The virtual PrEP program enables patients to confidentially receive HIV prophylaxis from providers. And we have successfully started a virtual PrEP program here at Stanford Children's, as we are one of the first pediatric hospitals to do so, headed up by Dr. Jeffrey Hart Cooper from our PCHA primary care group. Next slide. We wanted to highlight our diabetes clinic because they've done wonderful work in telehealth. They've embraced telehealth, starting by increasing their visits, as well as showing multiple provider uses, whether it be the endocrinologist, the diabetes educator, and the nutritionist. They also use remote monitoring for continuous glucose on patients, and the patients can transmit blood glucoses every 5 minutes that's sent to their electronic health record. Providers can look at that data quickly and make real-time adjustments. What's also great is they actually studied that no significant change in the hemoglobin A1C pre and post telehealth really supports the safety of telehealth as well in this setting. Lastly, they looked at the telehealth savings. So they found that distance saved was average of 211 miles per patient, a savings of 6.2 hours per patient, and a savings of $122 per patient per visit. Really impressive. Next slide, please. Our approach to COVID-19 in ambulatory obviously was important. Initially, we had everyone work together and come together to really find solutions. We initially looked at scrubbing schedules, making our urgents in person only, making our non-urgents rescheduled or moved to telehealth. When shelter in place occurred, we actually pivoted to a telehealth first model where we really saw the patient first in telehealth and triaged if they needed to be seen more urgently. We also, as we became more comfortable with telehealth, pulled back in or rescheduled as telehealth, and that worked very well as well. Moving forward, we are in a new normal, as everyone knows, and we are looking towards updating our ambulatory model to really embed these telehealth options in the future and look for efficiency models of how we can better utilize telehealth. Next slide. With regards to ambulatory changes using telehealth, we recognize that there are changes in all of the clinic setting. The roles are changing. MAs are not where the providers are. They have to probably do pre-visit through the phone maybe or through video. Patients and families change with their responsibilities. Sometimes they have to be involved in the visit. The provider actually has to have the patient, the parent do something with the patient. Technology support is very important now. We all have to be our own IT specialists sometimes. We have to be our IT specialists for our patients sometimes, and that's a change. Training, obviously, with that is important. Communication platform changes. We have to actually enhance our communication platform. And lastly, the analytic part, capturing this data. There's a lot of new data, new reports that need to happen in this new space. So this all equals a very new healthcare delivery model, which I think is very exciting, and we have lots of opportunities with. Next slide, please. Looking at the educational impact of ambulatory telehealth, we are now looking towards webside manner as opposed to bedside manner. How to make eye contact with the camera. Your actions are magnified. So if you're drinking a cup of coffee or eating a bagel, it's very apparent to the other end. And so just be cautious of that. From our COVID-19 pandemic, Dr. Huffman and our developmental behavioral pediatrics program developed a really innovative fellow training model and showed that with teletraining, the nature of supervision changed. They were able to observe more intensively without interruption. They were able to give actually feedback that was improved because they used chat features real time during the visit, and they were able to have the opportunity to observe practice skills like leadership, flexibility, and problem solving. Their manuscript was recently submitted, so we're excited to hear results of that as well. Next slide, please. In addition, we wanted to also just bring up presence. Presence is a purposeful practice of awareness, focus, and attention with the intent to really understand and connect patients. It's an evidence-based program started here at Stanford by Dr. Verghese Verghese, and Zolman that really offers a set of practices that foster humanism and connection to enhance patient experience and clinician well-being. The Presence 5 actions are prepare with intention. One of the suggestions are to stand up in between visits. There will be a lot of time where you're standing or you're sitting in front of a screen, and there's actually a concept of video exhaustion. And so you really need to reset. So standing up and taking a deep breath between visits is important. Listen intently and completely to start engaging your patient. Agree on what matters most, asking your patient what the priorities are and setting goals. Connect with, next slide, connect with patient stories to really engage your patient, and then explore emotional cues, tuning into your patient's emotions. This is also available on YouTube, and I have the link outlined, as well as we are going to be able to work with these folks to actually make a Stanford Children's Presence 5 video as well, to help looking at how we can connect our patients in virtual visits, as well as during the pandemic. Next slide. So before telehealth can really be adopted as a routine part of care, providers and patients really need to understand the strengths and limitations. The standard of care for any condition should be the same regardless of where the care is provided. And therefore, we need to really look at standardizing. Clinical assessments in a pediatric ENT study out of Australia looked at video visits versus in-person visits and found there was a very high concordance of diagnosis and management decisions. And these are the type of studies we need to continue to look towards. So we need to develop clinical guidelines for conducting appropriate and complete examinations, as well as checklists and observations to compare in-person to video visits and to identify clinical gaps. What we've done just recently in the past month here, because we have been doing so many video visits, one of my fellows, Dr. Pooney, looked at 4 different pediatric subspecialties with 22 providers over 40 video visits. And we looked at different patient types, surgical versus medical, really to see differences and similarities and how they were able to adapt to telehealth. So these are some of the recent results. 86% of the providers felt that the telehealth clinical assessment was complete. 77% felt that the physical exam was complete, which I think is really impressive because there is a difficulty when you're not right in front of the patient. And then 100% felt the telehealth visit was safer during the current times of a pandemic. We also observed patients, and here are some of the great observations Dr. Pooney saw. In a nephrology visit, they were able to inspect lines and tubes, even examine a fistula, possibly. In orthopedic surgery, they were able to show a patient how to remove a cast. In endocrinology, the endocrinologist was able to show a patient how to self-palpate their thyroid. And in rheumatology, the patients were able to grab their meds, and we could actually review the meds together and show what medicines they were using, as well as be involved in the exam. As a physical exam in rheumatology is important as we're looking at range of motion and getting the parent to help us with that. All of these observations, I think, continue to improve our way during telehealth.
All right, thanks, Tzielan. Tzielan, we're going to transition into inpatient telehealth. This is a picture of the Gartner hype cycle, one of many, and I like looking at these graphs because they give you an interesting picture of what is going on in a specific field. So this is a telehealth hype cycle from a few years ago, but it shows which topics are kind of very talked about, very hyped up, probably more so than their value is worth. Tells you which of those topics then becomes, people start to realize that it's not as valuable as it's initially seemed, and you go into the trough of disillusionment, and then people start understanding the real value, and the ones that that really have value will take off and eventually reach their plateau of productivity. So like I said, this is telehealth from a few years ago. And what you see is most of these interventions are in the ambulatory setting, with a few notable exceptions in the inpatient setting. So you see, interestingly, in this one, remote ICU is considered to be at its plateau of productivity. I will mention that that is in the adult setting. It really has not taken off still to this day in the pediatric setting for a wide variety of reasons, except in a few exceptions like Nemours. You also see telestroke, which has continued to take hold across the country, and we do have a telestroke program here that includes our pediatric services. You see teletrauma coming into play and telesurgery, which you're going to see a little bit more about in a minute. Pre-COVID, we did have several interventions that were inpatient telehealth related. So on the top left, you see an example of us doing a virtual triage from our emergency department to our Packard El Camino unit down in Mountain View. This is a method for the providers at Packard El Camino to make sure that the patient in the ED is appropriate before he gets transferred down there. This child looks very appropriate. In the top right, you see an example of our virtual handoff. So partly because our emergency department is so far away, it becomes very important to have a virtual handoff where all of the information from the emergency department can be transferred to the inpatient team. And we have started this in a couple services, and Liz Dorwart in the PICU is now starting this in the PICU. It can be a very significant tool for improving patient safety during that transfer. In the bottom left, you see an example of our virtual rapid response. This is our PICU team looking through the camera at a virtual rapid response at El Camino. I believe this is actually a simulation because it does become important to practice these skills virtually as well as in person, because there are very different sets of skills involved. And then finally, in the bottom right, you see an example of our virtual or telestroke program. The Stanford Stroke Center started a telestroke program in 2017. And as I mentioned, our pediatric neurologists do take part, which is incredibly important because pediatric stroke is so rare that it's critical that they have access to our pediatric specialists when they need it. We also had some very innovative examples. What you're seeing here is an example of telefetal surgery. Yair Blumenfeld, one of our maternal fetal medicine doctors, as well as Alir Kulali, our director of biomed, put together a very innovative process to allow experts in Texas to actually see into the surgical operating room, see the images, see the surgical field, and then speak over speakers to give Yair guidance as he performed two very critical surgeries, one on a fetus who had a spinal cord defect, and another who had a mass that needed to be removed before birth. That child with the spinal cord defect was born healthy and happy with her legs kicking, and the child with the tumor was also born happy and healthy. So truly incredible feats, and you can imagine the implications going forward of how this can change global education. Imagine our Stanford specialists being able to reach into any operating room in the world to guide trainees or young physicians who are just learning new skills and techniques. But of course, that was all pre-COVID, and just as in the ambulatory world, COVID-19 dramatically launched telehealth in the inpatient world as well. So as soon as the United States started preparing to cope with COVID, we started seeing a slew of information. This graph on the bottom right, I really like. This is from a publication that Duke just did, and it shows that blue line was the peak in demand for ambulatory telehealth as COVID hit. And then right behind it is that red line where suddenly we started getting the demand for inpatient telehealth as well. And this is the exact same trend that we saw here. There was a demand for inpatient telehealth for several reasons: to conserve PPE, and so you get this concept of electronic personal protective equipment, to increase and enable social distancing, and just to keep our patients and providers safe and limit the number of people that had to be together in one place. In addition to the publications, our informatics and digital health worlds are very tight, and you saw the listservs blow up. You saw a lot of webinars, And this podcast is one of my favorite podcasts, which has been having a different healthcare system each day talking about their telehealth implementation during COVID, including our own Anshul Pandey from Stanford Children's, who was one of the first people to speak. And you'll hear over and over through those podcasts all the innovative inpatient interventions that people have done. So here at Stanford Children's, an example of the type of interventions we've done are virtual multidisciplinary rounds, where you have 1 or 2 people going to the bedside to enable family-centered rounds, but then the rest of the team, the ancillary staff like pharmacists or case managers, or even some of the residents, joining virtually from other places around the hospital or even at home, thereby enabling social distancing and decreasing the exposure to patients on isolation. We also did teleconsults with iPads in the rooms where providers could join in from anywhere. And in fact, our psychiatry department was one of the most avid adopters of this technology, and they were able to work from home in many cases or wherever they needed to be and do these, continue their services through COVID while minimizing risk and exposure. Again, this gives you incredible insight into what might be possible in the future, where many of our specialists may have to cover inpatient consults at John Muir or CPMC or Packard Del Camino and Stanford Children's. And so by enabling this technology, we'll allow our specialists to be where they need to be, when they need to be, with a lot less driving. There's also been some very unique applications. Our pet therapists are now going to be starting teleconsults with the pet therapy dogs from their homes, so to enable that service while we are all protecting people from COVID. We also been doing remote family updates and teaching because of our limited visitor policy during COVID. It becomes very important that we are still connecting with the family members who are not able to join in the hospital, as well as virtual discharge planning. We had a particularly complex liver transplant patient that was getting discharged during COVID. We were all worried about his chances for readmission and whether his mom would be able to manage his condition at home, but he no longer needed to be in the hospital. So we arranged virtual discharge planning with the entire team and his primary care provider from our complex care clinic so that everybody could listen in virtually and make sure they were all on the same page. This is such an exciting concept that Lee Sanders and his group are looking at how can we enable this concept going forward so that every time a complex care patient is discharged, the complex care primary provider is involved in the discharge planning. And then finally, telemonitoring, where we do have cameras in the patient rooms, and our cardiology and CVICU teams have been using this to check in on patients virtually who are on isolation and might not otherwise get checked in on as often. Again, it conserves PPE and enables transfers from the CVICU to the cardiology acute care floor in a safer manner. There are several educational implications of inpatient telehealth, that some of which are exciting and some of which are challenges that we need to take on. So I need to attribute this slide to Keith Morse, one of our clinical informatics fellows, who also just submitted a publication on the educational implications of inpatient telehealth. But what he pointed out is that in some ways this is bringing back the operating theater, where you enable multiple people to watch either a procedure or a process with a patient, except you don't have quite this obtrusive audience sitting around looking at you. It's a little bit more subtle and less interruptive to patient care. And so this can be done in the ORs, like we saw with the fetal surgery case, or on virtual rounds. It suddenly gives opportunities for medical students or residents to join rounds from multiple different areas, from remote locations. It allows flexibility to work schedules. If you have a pregnant or immunocompromised or sick trainee who is not able to be in person, this allows them to continue their medical education and continue to be involved. For preceptors and coaches, this is also another really unique opportunity. We have resident coaches who will observe residents presenting on rounds. And you can imagine that this will enable those coaches to do it in an easier way without having to worry about the timing or traveling so much, and also, again, a little bit less intrusive. And so they can take notes remotely and then talk with the resident afterwards. Similarly, for nurse preceptors or pharmacy preceptors, the same concepts apply. And then finally, this enables people who are joining remotely to jump on their computer and look up quick questions to answers, or quick answers to questions that can help with clinical care and can help with the learning for the entire team. Of course, it does become a little bit more challenging then to assess the trainees' fund of knowledge in that case. So there are definitely considerations we'll have to think about as we go forward. There's also the risk of tunnel vision, where the trainee is only seeing what is being shown to them via the camera. So again, there are definitely considerations that we need to think of, and more work to be done on the impact of inpatient telehealth. There are ways to think about explicitly enhancing the educational value of telehealth, and Becky Blankenberg and her team did an amazing grand rounds a couple weeks ago talking about education during COVID, and they talked about the value of role modeling and explicit role modeling with a model of priming the trainee before they go into a situation, thinking out loud, and then debriefing afterwards. And this becomes even more important in telehealth, where the trainee may not be touching the patient, may not be participating in the exam, but if that role model, if that preceptor can really explicitly perform each of these 3 steps, they can enhance the value of that educational experience. All right, so let's move on to clinical research in telehealth. We'll talk both about clinical research about telehealth and clinical research using telehealth. There is a ton of work going on to research about the effects of telehealth. And this is incredibly important because, as both Vandna and Tzielan highlighted, there are a lot of differences that we don't yet completely understand how they will impact care. There is a group nationally that focuses explicitly on pediatric research on outcomes and utilization of telehealth. It's called Sprout. And this is a graph from a landscape survey they did a few years ago. And what I like about this graph is it shows what the barriers were that were identified from 50 different programs across 30 different states at that time. So back in 2017, these were the barriers. But if you look at right now during the COVID pandemic, you see that a lot of these have changed. So patient preference for in-person care, suddenly patients are preferring telehealth because it keeps them safe. When you look at provider preference or provider interest, provider time, training time, all of those things have become, are less of a barrier because we've had to pivot our care model so much and focus explicitly on telehealth. Additionally, when you look at reimbursement models or policy or policies, a lot of that has changed in the era of COVID-19, at least on an emergency basis. There is a lot of research about telehealth going on at Stanford Children's right now. This is a small sample, and you've heard of several of these. Dr. Pooney's work right now during the COVID era, Stacy Valenderer and Birju Patel, one of our CI fellows, just got a paper accepted on our inpatient telehealth deployment here and at SHC and Valley Medical Center. Sue Fernandez and Lisa Chamberlain are looking at health disparities in telehealth. Liz Dorwart is working with colleagues at UC Davis to study the impact of PICU-ED telehealth on mortality. As Tzielan mentioned, our diabetes team is doing incredible telehealth work, and you heard about the PrEP clinic work. Jen Carlson is working on virtual discharge follow-up. Elizabeth Shepard, Anisha Patel, Tom Robinson are looking at obesity. Angela Chen and David Rosenthal and Sita Turney are doing some very cool work having parental directed echocardiograms to enable cardiac telehealth. Dr. Bandari and Richardson are looking at telemedicine implementation in the PEDS pain clinic. And then, as we mentioned, there have been several publications recently submitted on the educational impact of telehealth. And I should mention, this is just a sample. I know I'm missing a lot more, but it is a very ripe environment for research, and there is much more to come. Telehealth also has significant implications for advancing clinical research. So there are several bodies of work going on to enable clinical research using telehealth tools. You can learn more about these from our Clinical Research Support Office, which is led by Carl Sylvester with Allison Howell and Sijo Thomas, who are really looking at different mechanisms to advance clinical research. Recently, we started piloting research recruitment through our patient portal. We also can do informed consent, and Tom Robinson's group has been very creative with this approach. We are now enabling remote clinical research monitoring. And of course, you can do your telehealth visits or your clinical assessment visits via telehealth. And oncology, which is constantly involved in clinical research, is doing a lot of their appointments right now via telehealth. All right, so let's just take a quick look at what's next. Clearly, the COVID-19 pandemic has transformed our telehealth landscape, and we expect that this will be a permanent transformation. There will definitely be, some return to normal, and there are definitely visits that are appropriate for in-person, and we'll see those. But I think now that both providers and patients have been exposed, become used to this platform, and seen the benefits, we will continue to see a dramatic increase in the use of telehealth in pediatric and obstetric care. There were several regulations that were loosened or altered during the pandemic, and we will immediately need to reassess those as we come out of this pandemic to see what sticks and what changes. For example, there was a relaxation of the HIPAA compliance of telehealth platforms. We do expect that to go away after this pandemic, and we'll need to make sure that everybody is using a HIPAA compliant platform. There were reimbursement changes, and CMS had much more relaxed reimbursement policies during COVID. We've been lucky in California in pediatrics in that we have had almost full reimbursement of pediatric telehealth visits at the same rate as in-person visits even prior to COVID. But we will need to continue to follow these policies as we come out of this pandemic. And similarly for state licensing requirements, there was relaxation of state licensing requirements across the country. Unfortunately, it's individual state by state. So for example, Nevada has a process where our providers can get immediate temporary licensing during COVID. This is incredibly important for a pediatric veterinary organization like ours, where we have patients coming from all over the country to see us. And if we want to be able to follow them when they go back home, it's important that, that we're able to manage these state licensing requirements. We obviously have a lot more work to do to optimize our technology platforms. This was a huge burden on our platforms, and we learned a lot of lessons, and there is an upgrade underway, and we will continue to update our platforms to offer the best experience for both patients and providers. And then finally, as Tzielan was mentioning, and as we're starting to do already, we really need to determine and support the right use cases for telehealth. So where is telehealth suboptimal? Where is it equivalent? And where is it actually better than traditional care models? And Tzielan gave that example for our developmental behavioral pediatricians. They're finding a lot more information by seeing the patients in their home environment. We also need to continue to work to figure out ways to overcome the socioeconomic barriers to telehealth that Vandna addressed, and that is an area of active work. This is just a graphic to kind of show what is the immediate need and what is the longer term need. And right now we're going to be focusing on hardwiring our virtual visits into practice and making all these temporary changes more sustainable. But in the long term, there is a much broader landscape for digital health and many more areas that we can reach into to expand our capabilities and improve the quality of care that we're providing. And then finally, I'm just going to mention real quickly a new interoperability rule that snuck in during COVID. This is an extension of the 21st Century Cares Act that was signed into law by Obama back in 2016. It was a proposed rule for over a year and a very hot topic in the informatics world, but most of the healthcare world is not aware yet. It actually went into law on March 9th, right as COVID was really hitting the nation. And so we have not yet seen the impact nor really been able to delve into this 1,700-page document to understand all of the implications. But it is designed to increase innovation and competition, increase interoperability, and really to increase patient access to their own data. So this rule mandates that patients must have electronic access to their entire medical record, including their labs and medications, their notes, And not only that, they must be allowed to download that data electronically to third-party apps, which is going to spark a whole new world of digital health apps on the market. And we'll have to consider how those help or hinder our provision of healthcare. So I think this rule, when we are able to finally start to implement it and really look into and understand it, will dramatically affect our digital health landscape. All right, I just want to end with a thank you. Our digital health team is truly multidisciplinary. It is, as Vandna mentioned, a tool for the delivery of healthcare, and so it involves everybody in the healthcare system. So thank you to our executive leadership, Cameron Dialb, Denny Lund, Ed Kopetsky. Thank you to the multiple teams and thank you to our operational digital health team. Vandna, Meher, Crystal, Kelly have been absolutely incredible throughout all of this. Our multiple different information services teams, so our unified communications team, which has been working around the clock for the last 6 weeks trying to keep our telehealth platforms up to date, our desktop field services teams, Epic, MyChart, training team, clinical informatics team, and 50 different volunteers from across the department who helped with immediate patient support and provider support during the fast ramp up of our telehealth. Our revenue teams, our compliance, risk, legal teams have constantly been at our side, helping us interpret rules and make sure that we're implementing telehealth safely and legally. Our partners at Stanford Healthcare, Topher Sharp and Chris O'Dell, have constantly shared their approach with us. We are constantly learning from each other and trying to advance care across the organization. Thank you to our trailblazing providers who have been incredible over the last few years, and especially over the last month and a half. Thank you for being so patient, working with us to figure out the right solutions. Same goes for our clinic staff and managers. And finally, our patients, our families, and our Family Advisory Council have been absolutely phenomenal in supporting us throughout our entire journey, and especially this crazy journey over the last month and a half. And finally, one last thank you to Vandna. This is a word cloud put together by her team, but as we mentioned at the beginning, she has been a truly phenomenal trailblazer in helping us launch our digital health program, and we will be forever grateful to her. And that's the end. Thank you very much.
That was a wonderful talk. Thank you guys so much. We have a lot of participants today, so obviously it's a very important topic to many, and a number of questions. And I would say certainly the recurring theme is about the physical exam. And I certainly found myself wondering about that as well. 3 or 4 questions about that. Someone says, are we giving up on the physical exam? How do you examine a pre-verbal kid over an iPad or remotely if they're in the PICU? Dr. Weinberg channels his inner Abraham Verghese and talks about the 2,000-year-old tradition of physicians touching patients for diagnostic purposes. This is rapidly replaced by technologies. What can be done in the context of telehealth to either not lose this benefit or complement its loss? And then another person asks about training and education and exam skills atrophying, and does this matter? So help reassure us about the physical exam.
So I'll start, and then I'll hand it over to Tzielan, who has lots of great stories about innovative ways that physical exam has been done. But I will start with, this is not the solution for every healthcare need, and we are not going to see a complete, abandonment of our traditional telehealth, traditional healthcare model. This is meant to be a supplement and may be appropriate for the right situations, and will be appropriate for the right situations in the right time. And that's why this investigation going forward is going to be so important, to understand where did we do telehealth because we had to, and it's not the right model, and we need to return to our traditional care models. Where is it as valuable, and we can use it as needed? And then, like I said, there are some places where telehealth will provide us more insight, more continuous, supportive, proactive models of care. And so we don't for a minute want to say that we are, advocating for abandoning complete physical exams and then traditional care models. We really want to figure out how do we create a new model that involves all the right types of care. So Tzielan, do you want to talk about some of the innovative ways that you've seen physical exams being done via telehealth?
As a rheumatologist, I live for physical exams. I mean, that's why I decided to become a rheumatologist. And so physical exams are actually very important in our field. And I'm the first to say that it's not the right fit for everything, for sure. But what we can do is extend, right? And so what I do with even my patients is that I see them one time in person and then the next virtual, because they live 5 hours away, and so you really work with the patients and the families to establish these connections. I think there are other ways to also establish care where you're actually having a discussion with the primary care that's closer to the family, and being an extender that way as well. Coordination of care is extremely important in complex care patients, where you're trying to get the right message or the right treatment to the patient, and there's too many cooks in the in the kitchen. And so those are some of the ways we can utilize telehealth. Again, I 100% agree with Natalie. It's not for everybody, and we have to use it wisely. And that's why we have to do more research looking at sort of what is the best use cases and when it's not appropriate.
Then a number of questions, any other comments on that? A number of questions about sort of functioning and privacy. The first question here says, issues WebEx functioning, how does one balance concerns about telehealth security versus poor functioning of a chosen platform? Someone else says, what are the problems already seen with relaxed HIPAA? And then I think Steve Alexander had a question about the sort of 3 platforms that we're using. I've lost his question. I might have bumped up here, but can you guys talk about kind of the functionality and HIPAA issues?
Sorry. So this is a great question. And, with COVID-19, we did see such a dramatic rise in usage of our platforms, not only for telehealth, but also for for conference calls, things like that. And so all of our vendors were overwhelmed by this dramatic increase. And definitely we pulled out, brought out every aspect of technical challenges that could happen during this. So clearly, I think what we've identified is that there is a lot of work that needs to be done to improve our platforms, both from a kind of technical reliability standpoint, but then also from an ease of use. And I think some of what we've seen with some of the freeware that's come out during COVID is that it's being adopted because the user interface is a little bit easier, but then of course there are the questions about HIPAA and security. So our platforms that we have and that we promote at Stanford Children's are secure. Our Epic integrated platform, our WebEx, and the Stanford Medicine Zoom. There were some issues with Zoom initially during the COVID crisis and around its security, and so we're continuing to follow that closely. But we believe these platforms are secure and are really promoting those. I think other areas of the country did not have these types of platforms in place. And so they've had to rely on whatever they could get their hands on just to keep the patients as safe as possible. And it always becomes risk-benefit analysis of can we provide care in any format versus the security of the platforms. I don't know of specific incidents, except for like the Zoom bombing incidents around security breaches during COVID, but I am sure that we will see some and hear more as it comes out. But yeah, I mean, it is a tough challenge. We need to continue to work to improve our platforms from a reliability, from a usability, and from a security platform going forward. And there is and will be a lot more work on those fronts. Tzielan or Vandna, did you have anything to add?
just to point out that a couple questions have been answered too, if you want to read the answers to those. Some of these logistic questions particularly have been answered. There's a question here about licensing. Someone says, great presentation, I agree. Rules for many states, and particularly for California, is that you have to have a license in the state in which you're treating the patient. So if a patient is in New York, you have to have a New York medical license. With COVID-19, some states are waiving this, but not all. How do you see patients internationally or perhaps in other states who are strict about having a medical license?
Vandna, you want to take that one since you've been working so much with our legal and risk team?
Yeah, so for international patients, if you are on the Second Opinions platform, we can definitely easily do second opinions internationally. For any new country where you do want to see patients, please reach out to the digital health team and to Natalie Pageler, and we will rope in legal, risk, and compliance to help us evaluate how we can see those patients in those specific destinations. Every geographic location has very unique laws, and even sometimes within states, there are certain counties you can't even practice in, but you can practice in the remainder of that state. So these are very complicated issues, but our legal team is willing to work with us on each of these questions.
And just to point out, we've gone a few minutes over, but there are lots of questions here, so we'll just take a couple more minutes, and I appreciate the speakers' willingness to do this. There was a question about people canceling visits and stating that they just want to see doctors in person. And what do you guys think about that? What should we do about that?
Yeah, it's a great question, and Sue Fernandez, Liz Chamberlain, and the diabetes team are all doing surveys with their patients to look at the reasons why people are turning down telehealth clinic visits, and it is a wide range of reasons, from just wanting to see somebody in person to the socioeconomic barriers that Vandna mentioned earlier. And I think once we get out of this pandemic, we have to respect the patient's preferences, and where in person is the right thing to do, definitely do that. I think what we've seen through the COVID pandemic, though, is that people who were initially reticent to try telehealth, once they tried it, really appreciated the value of it and could see that it could be a part of their care going forward. So a little bit of it is just this kind of change management of getting people exposed and comfortable with it and improving the experience so that people are willing to try it. Tzielan, do you want to?
No, that's exactly what I would have said. So yes.
Someone asked about Doximity video calling. Super easy, needs less internet speed. Phone calls are secure. Any thoughts on that?
So that's one of the freewares I mentioned. It is something that we are looking into. It is very easy. There are questions and challenges. Right now, it's being really reviewed by our legal department because there's a few interesting things in their terms and conditions, and it is not yet been reviewed by our security team, so not yet considered HIPAA compliant by our security team. So, but that's the type of thing that we need to continue to look into and really make sure that we are using the right solution with the right security and right integration. It's one thing when you have to just respond to an emergency and have no other options, but I think in this case we do have other options. So until we can ensure the validity and the safety of that, would prefer to use our primary options.
Great. A few helpful comments here by some of our cardiologists about things that have been working well for them. And maybe we'll close with another privacy question. Has any medical visit actually been Zoom bombed?
I've heard legend. I don't know people personally. I
haven't heard either.
Okay, good.
Yeah.
Yeah, it's more of an urban legend right now, as far as I know. There have been some issues with some misconnections, and so all of a sudden being connected with the wrong patient, but not intentional Zoom bombing that we're aware of.
And we equate the misconnections as accidentally walking to the wrong room when you're in clinic. So.
Fair enough. Fair enough. All right, well, we'll wrap up. Thank you guys so much. And for all the participants, this is recorded, so you can access it again later. What a wonderful talk, and thank you all so much.
Thank you, Alan.
Thank you.
Thank you.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.